a distinct pleasure to introduce Dr. Aboulhosn for Grand Rounds today. Dr. Aboulhosn is a professor of medicine at the UCLA David Geffen School of Medicine and director of the Ahmanson UCLA Adult Congenital Heart Disease Center. The Ahmanson UCLA ACHD Center is one of the largest of its kind in the US and serves nearly 4,000 patients per year. Dr. Aboulhosn has extensive mentorship and research experience in ACHD, in particular transcatheter, congenital, and structural procedures. He is currently and has been an investigator on multiple NIH or biotechnology-funded multi-center clinical trials and is the founding member and previous president of the Adult Research in Congenital Cardiology Network. Furthermore, he is actively involved in the AHA related to the development of clinical practice and care guidelines in the ACHD population, with Fontan-associated liver disease being an ongoing important area of interest. He additionally specializes in the management of pregnancy in patients with congenital heart disease and has co-authored a number of manuscripts on this topic, including a scientific statement from the AHA on management of pregnancy in patients with complex congenital heart disease in 2017. Dr. Aboulhosn, thank you so much for giving us Grand Rounds today. We're all very excited to learn.
Thank you so much, Patrick, for asking me to speak and also for that nice introduction. I think the bio sketch that I gave you was for a grant that Dr. Afshar in maternal fetal medicine was putting in for the NIH, and so hence why the focus on the pregnancy. Let me share my screen and I'll go ahead and get started here. Okay, can everybody see my screen okay?
Yes.
Patrick, can you see it all right? Okay,
yeah,
perfect.
It's perfect. Yeah.
Okay, awesome. Let me just change the display settings here. Okay, great. So this is a talk that, unlike my usual Grand Rounds that I give or talks that I give to the fellows, which for the past decade plus have focused a lot on transcatheter valve work and transcatheter interventions, going to change gears here and actually give more of an overview talk on adult congenital heart disease. Full disclosure, this was actually an invited keynote lecture that I gave about 2 months ago at the Royal College of Physicians in London. There was the Paul Wood keynote speech for the European Society of Cardiology ACHD meeting that they had there. And so I gave it on defying the odds and challenging the status quo, the saga of ACHD. And so we'll just kind of go through the story of adult congenital heart disease through the work of some of the folks that have led us to where we are today. And so it's going to be truly a saga that we'll be discussing here. A saga is basically a form of Norse storytelling, and that is what I will do, and I'll show you some data as well. So there'll be a little science in there. Pertinent disclosures, none of which are applicable today, but valve work with the various companies and closure devices and things of that sort, and then work with the American Board of Internal Medicine, chairing the exam committee. We're not going to give away any exam questions today. So intro here. In the realm of adult cardiology, ACHD is widely viewed as really a minor field, often a boutique field, right? Compared to the giants in cardiology, electrophysiology, heart failure, coronary heart disease, etc. And this has unfortunately resulted in less attention and investment in ACHD when compared to other areas of cardiology. And, where we see this is oftentimes in the exclusion of congenital patients from various trials, whether they be, heart failure therapy trials or the latest devices to treat, mitral regurgitation or tricuspid regurgitation or et cetera. Oftentimes they will exclude ACHD patients because they represent a wide spectrum of potential diagnoses, varying physiological presentations, and various anatomic considerations. And hence, we're not talking about just one condition here or just a small group of conditions. We're talking about really an umbrella term that covers hundreds of potential diagnoses that can present in a myriad of ways. Many of our patients really have been considered historically too complex and high risk to receive the same attention as others. And that goes back to the point that I brought up of exclusion from various trials. And so oftentimes, what we're doing is we're sort of borrowing from what has been published in other areas and then applying it with really very little evidence specifically pertinent to the ACHD population. And if you look at things like the use of some of the guideline directed medical therapy that Dr. Fonarow has really advanced over the last few decades. Many of those trials are not done in ACHD patients. So things like SGLT2 inhibitors, the recent publication in JACC heart failure on the use of these medications, and also in JACC, actually, the use of these medications in ACHD patients. And what you find is that those are not randomized, prospective, placebo-controlled trials, but more case series and descriptions of safety in these patients and potential benefit in these patients. So certainly we don't have the same amount of evidence for the things that we do, which disadvantages our patients. And hence, and this is really what this talk is about, it's been through the works of mavericks that have challenged the status quo that this field has actually developed. And our patients also really deserve an immense amount of credit. Most of them were dealt a bad hand that they had nothing to do with. They were born with single ventricle physiology, born with the tetralogy of Fallot, and the vast majority of them have really tried to make the best of it. And so, we should also tip our hats to our patients for partnering with us and on this journey. So I'm going to start here with 1897 in this publication by Victor Eisenmenger. And what he did is, Victor Eisenmenger, he himself has such an interesting story, actually. If you're into the history of medicine, you should read up on Victor Eisenmenger. He was actually the court physician for the Habsburg court at the turn of the century, and was actually the physician for the Archduke Franz Ferdinand. And for those of you that like history, the Archduke Franz Ferdinand was murdered in Serbia. Actually, no, it was actually in Bosnia, in Sarajevo. In 1914, he was shot by an assassin, and that's what sparked the beginning of the First World War. So there's a connection there to Victor Eisenmenger. Dr. Eisenmenger was not on the scene. The other thing that's very interesting about Victor Eisenmenger is he was not a cardiologist. He was actually an otolaryngologist. He was an ENT doctor that worked at this clinic in Vienna that basically took care of ENT problems. So there you have it. And I think the way he got involved with all of this was because of hemoptysis and issues with bleeding in this population. But be that as it may, in 1897, he presents this case of a 32-year-old man with clubbing of the digits, early childhood cyanosis, who presents with dyspnea and peripheral edema, and on auscultation has a buzzing systolic murmur over the apex and a loud second heart sound. The patient was readmitted shortly after his first visit when he collapsed following a large hemoptysis, and the postmortem was done by Dr. Eisenmenger and revealed a large membranous ventricular septal defect and hemorrhagic pulmonary infarction. And it was from this description that we then went on, and it wasn't called the Eisenmenger syndrome at that time. It wasn't until decades later when Maud Abbott gave him credit for this description. But he really, at this point, connected the pulmonary hemorrhage and pulmonary infarct to the ventricular septal defect, and actually spoke at this point, and this is a pretty long treatise here, but he did touch upon the suspicion that the pulmonary circuit was extremely hypertensive because of the presence of a ventricular septal defect. So this is kind of where this started. And then from there, we moved to 1958. And this is, for the fellows in the room and anybody, again, that's interested in medical history, if somebody is covering a paper, and I'm going to spend quite a bit of time on this paper that was published in 1958 by Paul Wood, Professor Paul Wood, who was at the Royal Brompton Hospital in London. And it's really a classic treatise on what is the Eisenmenger syndrome and how pulmonary hypertension occurs in patients with congenital heart disease. And he characterizes here 127 cases of patients with Eisenmenger syndrome. Hemoptysis was the most common cause of death, as was described by Eisenmenger himself in 1897. Atheroma of the pulmonary arteries were common, and this is fascinating because we actually see this quite a bit in these patients that were born with large central defects like VSDs or PDAs or aortopulmonary windows and have had pulmonary hypertension from the get-go. It's fascinating in that they develop atherosclerotic plaquing, lipid-laden plaques within their pulmonary arterial circuit, yet will have a paucity of atherosclerosis in their systemic arterial circuit, and that's the aorta and the coronary arteries. They will rarely actually have myocardial infarctions in the classic sense. They may have coronary thrombi that occur, but oftentimes the coronary circuit is not calcified, and on postmortems you don't find atherosclerosis here. So really a strange kind of paradox that is seen in these patients. Pulmonary arteries less than 1 millimeter in diameter had a thick muscular media, very similar to the structure of the pulmonary arteries in the fetus. And he hypothesized that this was a failure of this musculature to regress as the patient grew. Patients with reverse central shunts, and you're going to hear this quite a bit, where I'm going to talk about central shunts, which are post-tricuspid valve shunts, versus pre-tricuspid valve shunts, atrial or vena cava level shunts. And these are very, very different. So we'll start with central shunts. Patients with reverse central shunts and pulmonary hypertension differ from patients with a reverse shunt at the atrial level in the way they present and the degree of pulmonary hypertension they may have. And so when we say things like, oh, this is a patient who has an ASD with Eisenmenger syndrome, we are actually misspeaking. So we should not say that. That would not be Eisenmenger syndrome. That's not what Eisenmenger described, and they behave very differently. And in the next, hopefully 5 to 10 minutes, I'll explain to you why that is. Cyanosis, and this is actually one important difference, is that cyanosis dates from infancy in the vast majority of patients with a large non-restrictive ventricular septal defect, but does not start until adulthood in the vast majority of patients who have ASDs, who then later develop pulmonary hypertension. So very different natural history there. So in the normal newborn, the pulmonary vascular resistance is actually suprasystemic. And at birth, it drops to the systemic level. And within a few hours, and then thereafter, within 24 to 72 hours, will slowly decrease to a subsystemic level, about 10% of what the systemic level of arterial resistance is. So there's 4 basic questions here that we have to answer. Number 1, what is the cause of suprasystemic pulmonary arterial resistance in the fetus? Number 2, why does it drop precipitously after birth? Number 3, why is this rapid fall halted temporarily near systemic resistance? And number 4, what is then responsible for the subsequent slower decline to normal? And this is a direct quote from Paul Wood from this manuscript. In the correct answer to these 4 questions lies the secret of the Eisenmenger syndrome. So let's tackle question number 1. And if you'll excuse my attempts at trying to do my own sort of diagrams of just ink sketches with some Photoshop here to try and make it easier for us to understand what it is that I'm saying here. So number 1, what is the cause of suprasystemic PVR in the fetus? So the resistance to flow in a tube is increased by kinking of the vessel, right? If you just take a water hose and you kink it a couple of times, my gosh, right? Your you're not going to get any flow out of it, right? And your faucet's going to leak. And so the fetal lung is actually collapsed, and the pulmonary arterial bed is actually coiled up and kinked, and hence suprasystemic pulmonary arterial resistance occurs. There's very little blood flow going through the lungs in the fetus, almost no blood flow. Question number 2. Why does pulmonary arterial resistance drop precipitously after birth? So as the lung expands, the vessels uncoil, flow increases, and the arteries will then dilate. And this is another quote from Paul Wood here, which is really one of my favorite quotes, actually. In a matter of a minute or so, and aided by lusty cries, the lungs are fully expanded, the vessels are wholly unfurled, and the pulmonary vascular resistance is at systemic level, or at least 5 times lower than in utero. For those of you that are listening to this lecture that have been here a while, who does this sound like? This sounds just like Joseph Perloff, the way Joe Perloff used to talk. And he was the founder of the center here and the founder of the field of adult congenital heart disease. Well, back around 1958, guess who was a Fulbright scholar in London with Paul Wood for a year? And that was Joe Perloff. So Joe Perloff was very influenced by the work of Paul Wood. And if you read Perloff's textbooks and his writings, this is exactly how he writes. People just don't write like this in medicine anymore. But essentially, when the lung expands, you're uncoiling these pulmonary arteries, and you are dropping the resistance right away. Number 3, why is the rapid fall halted temporarily near systemic resistance? So the fetal pulmonary arteries are thick and muscled because they've been subjected to systemic pressures. The right ventricle is every bit as thick and powerful as the left ventricle because it's been pumping into a high resistance system through the ductus arteriosus. It's basically been pumping to the systemic arterial circuit. And therefore, in fetal life, the pulmonary vascular circuit differs very little from the systemic arterial circuit. If I were just to give you cross sections, it would be very difficult to tell the difference between one and the other at this point. And so, therefore, this doesn't just resolve right away within, the first hour of birth. This takes time to decrease. So, number 4, what is responsible for the subsequent slower decline of the PVR back to normal? And that is, number 1, the relaxing effects of alveolar oxygen tension on the muscular arteries. If you have a patient that has high pulmonary arterial resistance, and you're somewhere where you need to bring that resistance down and bring it down quickly, and you don't have nitric oxide and you don't have prostacyclins, you know what? Put that patient on full flow oxygen, 15-liter face mask oxygen, and that will help bring the resistance down some. So that's number 1. Number 2, the closure of the ductus arteriosus. So now all of a sudden, that pulmonary arterial bed is no longer exposed to the same amount of high pressure and high flow. And number 3, as the pressure falls, the muscular arteries will basically atrophy and so diminish their resistance to forward flow. And then subsequently, you get a decrease in the right ventricular muscle mass. And the right ventricle thins out and becomes the volume pump that we are all used to in the adult patient, right? Or in even the normal child, right? It's a thin-walled structure that has a bellows function, differs completely from the left ventricle at that point. Recall that the right ventricle is really a late evolutionary adaptation to life on land, to breathing air. It's meant to pump blood to the lungs, a low resistance circuit. So it's good as a volume pump, but as we grow, is terrible as a pressure pump. All that is necessary to prevent these natural forces from lowering the pulmonary vascular resistance to normal is a sufficient increase of flow to keep the pressure at systemic level or close to systemic level. Pulmonary vasoconstrictor tone must then remain high, and the muscular arteries will not atrophy. And so therefore, somebody who's born with a large non-restrictive ventricular septal defect doesn't develop pulmonary hypertension. Okay, they're born with pulmonary hypertension. They will develop cyanosis when that degree of pulmonary vascular resistance exceeds the systemic vascular resistance, but they are not born not having pulmonary hypertension. And that's important to keep in mind. So why do large ASDs behave differently? Okay, so number one, at birth, the left and right ventricular mass, as I've told you, are quite similar. There's very little difference in the ventricular diastolic tone. When we talk about diastolic tone here, we're talking about your, diastolic filling pressure, your EDP, for example. If you cath patients now and they're adults, and a normal patient may have an LVEDP of 8 or 10 millimeters mercury, but the RVEDP is like 3 millimeters mercury. At birth, those EDPs are very similar. And so there's no appreciable flow across the atrial septal defect in either direction. And what's important to remember here is what drives shunting across an ASD is not the RV systolic pressure versus the LV systolic pressure. It's actually the diastolic pressures, okay, the diastolic tone of these two ventricles. Number two, left to right shunting across an ASD occurs as right ventricular mass and filling pressure slowly decrease. Remember that I said that may take 1 to 2, 3 weeks for that to happen. So therefore, appreciable shunting through the ASD doesn't occur that early. There's regression of the pulmonary arterial musculature, and the PVR falls to normal before the interarterial shunt gains much momentum, or interatrial shunt, not intraarterial. It's difficult for the Eisenmenger reaction to then develop later, because once the pulmonary vessels are fully involuted, an increase in pulmonary blood flow is typically met with a decrease in pulmonary arterial resistance until much later in life. And so, that's why you'll see the ASD patient be like, 65 years old with a huge ASD and only mild pulmonary hypertension, or sometimes moderate pulmonary hypertension, but not the same kind of severe pulmonary hypertension from the get-go. So when you see a person who has an ASD, 1-2 centimeter ASD, who's 35 years old and is cyanotic and has clubbing, blue lips, and has severe pulmonary hypertension, then what you're seeing there is actually the combination of idiopathic pulmonary hypertension or some other form of pulmonary hypertension and an atrial septal defect. Now, could the ASD be contributing some? Maybe, but it is not the sole cause of that patient's pulmonary hypertension or that severity of the pulmonary hypertension. And that's important to keep in mind. And as a matter of fact, oftentimes an atrial level shunt is actually a good thing in these patients, because it actually provides a pop-off for a failing right ventricle. So one needs to keep that in mind, because I get called all the time nowadays about, this patient's got a lot of pulmonary hypertension and has an ASD. Should you close it? Well, actually, no. The answer is do not close that ASD. And if you look at our guidelines from the American Heart Association in 2019, it's actually a class 3 indication, one of those red class 3s, harm. Like, do not do it if you have severe pulmonary hypertension. So this is why these things behave differently. And hopefully, just going into this treatise in a little bit more detail helps explain that to you folks. And later at the end, I'd be happy to take questions about it. But what is the morbidity that occurs with Eisenmenger syndrome? Well, this is from a graphic that we published many years ago with Tom von Driska. I think it was in Circulation Research or something like that. But anyway, what you're seeing here is a patient, just a picture of a patient that I drew who has lower extremity edema here. They have clubbing of the digits. This is actually from, I was in Dr. Mike Fishbein's office. I saw that Dr. Fishbein had joined a little earlier, and hopefully he's still on. But I don't know if you remember this, Mike, but I was in your office and I saw that you had this up on your wall. And so I took a picture of it, and it's amazing. It looks just like a heart, but that is the sort of pulmonary arteriolar circuit there with H&E staining, showing all of the classic findings of severe pulmonary hypertension. You get these huge aneurysms of the pulmonary arteries in these patients, and occasionally these will rupture. And hemoptysis, as you saw from the description by Wood, as well as Eisenmenger's description, is not uncommon. And actually, compression of the left main coronary artery is also a real problem in these patients, because what runs right under this pulmonary artery is the left main. And so that can be compressed so that they can end up having angina. And we've even had cases where people have come in with cardiogenic shock and had to actually have left main stenting for this problem. You'll get RV hypertrophy, RV enlargement, heart failure, diastolic heart failure of the right ventricle, and eventually you can develop systolic heart failure as well, and obviously the severe pulmonary hypertension. So other things that happen that I didn't describe here: cyanosis and reactive erythrocytosis. So oftentimes people will say, oh, this patient's got a hematocrit of 60 or 65, so they have polycythemia. They do not have polycythemia, okay? Polycythemia is an increase in all cell lines, right? White blood cells, platelets, red blood cells. That's not the case here. This is actually reactive erythrocytosis that is in response to the fact that these patients are cyanotic. So, you know, their EPO levels are just through the roof. As a response to the cyanosis, they increase their oxygen carrying capacity by increasing their red blood cells. That can cause hyperviscosity. So if these patients are dehydrated, their blood turns into sort of like the Rio Grande. It's kind of a really muddy river. And it looks, if you end up doing an echo on them, you're looking at their IVC, it looks like they have sort of this smoke, echo smoke floating everywhere. And that's true, because that's exactly what they have. They can get thromboemboli because of that. Infective endocarditis is a real problem in these patients as well, of any valve. But the tricuspid valve is oftentimes involved. Hemoptysis, we already talked about. All kinds of arrhythmias. Now, what we're seeing nowadays is these patients are dying less of pulmonary hemorrhage because we now have pulmonary vasodilators that we treat them with, and having more issues with heart failure and arrhythmias. And so, you know, the risk of ventricular arrhythmias, sustained ventricular arrhythmias in cyanotic congenital heart disease is over 10%. So this is like a very high-risk population for sudden cardiac death. And so those of you that are on the CCU service probably have seen some of our patients, and you'll see that more and more we're putting sub-Q ICDs in these patients because we don't want indwelling ICD leads in somebody that has a big VSD and the possibility that a thrombi can then form on those leads and then embolize. All of them have exercise intolerance, okay? Nobody's got NYHA class 1. It's pretty much unheard of. I mean, who knows? Maybe you can never say never, right? But find me one, please. Heart failure, we talked about. Multi-organ effects, okay? This does not just affect the heart and the lungs. It affects all types of organs. It affects your bones. It affects your kidneys. It affects your liver, your brain, and so on and so forth. And I'll go on about that a little bit further. I talked about pulmonary artery aneurysms and then the coronary compression. Okay. Now, let's fast forward to the time of Jane Somerville. So Jane Somerville, the lady whose picture is up there, is a really a massive figure in the field of ACHD. When ACHD was developing here in America under Joe Perloff here at UCLA, actually, in the late 1970s and 1980s, the same sort of thing was happening across the pond in London at the Royal Brompton under Jane Somerville. And so she's the one that started the adult congenital clinic at the Royal Brompton. And she and her colleagues really deserve a lot of credit for looking at what the factors were that related to deterioration and death in patients with Eisenmenger syndrome, and also looking at survival probability in this population, depending on whether they have simple or complex disease. So this particular study, and this is again just a quote from their conclusion, offers insights into the predictors of death, the natural history of patients with Eisenmenger syndrome, which is much better than pediatricians appreciate. Prevention of complications and avoidance of mistakes in management, which cause premature deaths. And this is key. She really did focus on this and how we were making a lot of mistakes in the management of these patients, and I'll mention some of those. Such patients may live to the 5th and even the 7th decade with sensible, informed medical care and protection from special risks. And what are the special risks and what are the medical mistakes, the iatrogenia here that these patients have? Well, one is phlebotomy. Seriously, this is people see a hematocrit of 60-65%. Patient has a headache, doesn't feel well, short of breath. Well, send them to the hematologist and bleed them. Well, it turns out that actually if you phlebotomize these patients, they do a lot worse. Why? Because this is reactive erythrocytosis. If in extreme cases you need to phlebotomize these patients, then you need to give the same volume back of fluid that you took away in blood. And so avoidance of phlebotomy was really important. Another one that was really important is understanding the risks of pregnancy in this population and advising very, very strongly that these patients should not become pregnant because the risk of morbidity and mortality in pregnancy is very, very high in patients that have Eisenmenger syndrome. Another one was avoidance of unnecessary anesthetics and really an understanding by anesthesiologists that were treating these patients that these were very, very fickle patients that did not respond well to anesthetic agents. And so therefore, when a patient of ours that has Eisenmenger syndrome is undergoing any procedure, we pretty much say that has to be done in the Ronald Reagan OR. This isn't something you just go do at some surgery center. And it needs to be crewed by anesthesiologists that have expertise in this area. Oftentimes, these patients need to be pre-treated with inhaled nitric oxide or prostacyclins before going under anesthesia. We should be prepared to actually support them as well if they crash. ECMO as an example. Usually indwelling Swan Gans catheters don't give you much information in these patients because the PA pressures are going to be the same as your systemic arterial pressure. So an arterial line should suffice in most. But really protecting them from these special risks or something that, those of you that, again, are CCU fellows or on service will hear us talk about all the time, which is bubble filters, particle filters. Okay, putting bubble filters on the IVs, because if you inject a cc of air into this patient, where's it going to go? It's not going to go to their lungs most of the time because they'll be shunting right to left. It's going to go to their brain and cause them to seize or have a stroke. So all of these things, really, Jane Somerville deserves a lot of credit for highlighting. And, I saw her in London at this meeting, and we had a fantastic dinner at her home. And she's still as sharp as ever, as witty as ever. And if you make a mistake, she lets you know it. How about here at UCLA? So here at UCLA, we had Dr. Perloff that I mentioned earlier, who's the founder of the center that we currently work in. And he talked about the importance of avoiding phlebotomy. And I'm not going to go into it any more than I did before, but just a quote from him: a major cause of hematologic morbidity was iron deficiency induced by inappropriate phlebotomy. Erythrocytosis is a desirable adaptive response to hypoxemia in cyanotic congenital heart disease. Phlebotomy should be reserved for temporary relief of major hyperviscosity symptoms or to improve perioperative hemostasis if these patients are bleeding. And, it's even when I arrived at UCLA and in the early part of my career here, I still had to oftentimes call the offices of outside cardiologists and hematologists to let them know, thank God here we weren't doing it much at UCLA anymore, tell them to stop phlebotomizing these patients. And I would say that overall this message has now come across to most people, at least in large centers. Then we fast forward now to the time of Michael Goudzoulis. So now Michael Goudzoulis took over from Jane Somerville at the Royal Brompton. And back in the early pulmonary vasodilator era, people thought that if you gave pulmonary vasodilators to patients with Eisenmenger syndrome, that you would actually drop not just the pulmonary arterial resistance, but also the systemic arterial resistance, and that you would not improve the cyanosis, and that if anything, you'd make them worse because you wouldn't even drop the pulmonary arterial resistance because everyone was convinced that this was irreversible pulmonary arterial damage, irreversible pulmonary arterial resistance, and that pulmonary vasodilators had no role whatsoever. And we should take responsibility here as well for that, in that, Dr. Perloff and, our team here at UCLA were not early adopters of pulmonary vasodilators. I remember having a journal club at my home in 2005 about this topic and going over some of these papers that were published by Dr. Gadzoulis. I think the first one that we went over, the safety and tolerability of bosentan in Eisenmenger physiology, and the concerns that our team had about making our patients worse if we did this. And so this is where really Michael Gadzoulis was a real maverick, in that he swam against the tide, and everyone told him, well, this would not work. And he said, no, I think it will work. And you know what? It turned out that he was right. And therefore, he and some of the other leaders in the field at that time, Michael Landsberg in Boston as well, Nazareno Gellier, designed the first prospective, double-blind, randomized, placebo-controlled trial in adult congenital heart disease. Can you believe this? Before 2006, we had not had a published trial that was actually placebo-controlled, randomized, and prospective in this field. I mean, Dr. Fonero is probably just like, oh my God, are you joking? But this is, everything else before this time was just opinion and case series. And so really, I think this is where Michael and, these pioneers deserve a lot of credit. And the Breathe 5 trial basically showed us that, no, we were wrong. That pulmonary arterial resistance actually can come down if you give people pulmonary vasodilators. In this case, it was an endothelin receptor antagonist, bosentan. And you can see this is a small trial here, funded at the time by Actelion, which has now been bought up by Janssen, and they now make macitentan as well. So, they showed a significant decrease in pulmonary arterial resistance, and they showed that patients that received bosentan also had an improvement in 6-minute walk distance by about 53 meters. And then they also showed that functional class improved, and that the therapy was extremely well tolerated, and hence we all started putting our patients on pulmonary vasodilators. And now if you see an Eisenmenger patient or a congenital patient with pulmonary hypertension, the vast majority of them are being treated with pulmonary vasodilators. And I think Michael deserves a lot of the credit for that. The other thing that Michael Gadzoulis deserves a lot of credit for is also the risk stratification of these patients. So if you recall, I had spoken earlier about some of the work of Jane Somerville, also at the Brompton, and showing that this is a multi-system disorder and how to avoid, creating problems for these patients. Well, look at how much more developed this is now that we are in the 2020s, right? This was a review that was published in 2022. And if you just start here, the importance of holistic supportive measures for patients with Eisenmenger syndrome, and all of these preventive measures, and how they can stay out of trouble. All of the things that I kind of mentioned, but are much more defined now. And then here you have this pyramid of, sorry, go ahead. Did somebody have a question? Oh, I think maybe somebody just didn't mute. Okay, no problem. If somebody has a pressing question, stop me. But otherwise, I'll take questions at the end. So what did we do here? Well, what we have found now is that we have this sort of pyramid scheme for, that's a bad way to put it, but this pyramidal approach for how we approach Eisenmenger syndrome patients. So almost everybody is getting, because everyone's symptomatic, everyone's getting an ERA or a PDE5 inhibitor. Okay, and then there is now oftentimes escalation of therapy to not just oral therapy, but combination therapy. We try to avoid intravenous therapy in these patients, right? So we're trying to avoid, IV Velitri and IV Flolan, the prostacyclins in these patients, because we are trying to avoid chronic indwelling intravenous lines. Because if a thrombus forms on a PICC line, then again, there's that risk of paradoxical embolism. So if we're going to favor parenteral therapy here, then what we're trying to do usually is use subcutaneous therapy, something like sub-Q remodulin. And this is where, honestly, we now work very closely, and we're blessed at UCLA to have a great PH team with, the likes of Raj Sagar and Rich Chanik and their team. And so we work really hand in glove with them, managing our patients together. And we've been very, very happy actually with that alliance with our colleagues from the pulmonary group. But often we'll escalate these patients to triple therapy and then begin thinking about organ transplantation. And then thereafter, start thinking about, if patients continue to be symptomatic or worsening symptoms, etc., heart versus heart-lung transplantation. And I'm not going to go into that in a huge detail because it's actually quite a complicated decision tree, whether to pick just a heart transplant, a lung transplant alone with repair of an intracardiac defect versus heart and lung transplantation. Suffice to say the following: you're better off getting a lung transplant alone with defect repair if you have an ASD. But if you have a ventricular septal defect, you're better off getting a heart and a lung transplant because of the ventricular dysfunction that may be related to the VSD repair. And we'll leave it at that. So now let's go to a patient story. This is Kevin's story, okay? And for anybody that was on the CCU service, I don't know, maybe a few months ago, you might have met Kevin. So he was born in April of 1958. His congenital diagnosis was detransposition of the great arteries with non-restrictive ventricular septal defect and a hypoplastic morphologic left ventricle. So the guy's got single ventricle physiology, big VSD, and he was diagnosed at 2 years of age. He became increasing, and he did not undergo any surgery early on in life. This is in 1958. Nobody would have been able to repair this. He became increasingly cyanotic during adolescence and young adulthood. He became even more symptomatic with shortness of breath and fatigue. He underwent a palliative mustard procedure without VSD closure. And a mustard procedure is basically rerouting of the pulmonary veins and the SVC and the IVC to the contralateral ventricle. And it allows for streaming of blood. Blue blood streams to the lungs, red blood tends to stream to the aorta, and that can improve cyanosis. You just don't really see these surgeries anymore. So these are historical surgeries. And that's the thing about, a field like ACHD. Not only do you need to know what's happening now, but you have to understand your history because your patients have had these historical procedures done. And so that's really, really key. He started having hemoptysis in his teen years and had massive hemoptysis as a middle-aged adult that required treatment with coil embolization. He had atrial and ventricular arrhythmias. He has a sub-Q ICD. He was started on an endothelin receptor antagonist, a PDE5 inhibitor, and also oral prostacyclin. He's had a cerebral abscess requiring drainage. He's had multiple embolic strokes. And the latest one was just a few months ago, in February of 2024, and he was hospitalized for 3 weeks during that time. He was initially nonverbal, but now is recovered fully with good rehab. Here's what you don't know about Kevin from just his medical history. Kevin's happily married to his lovely wife, Michelle, pictured there. Kevin became a high-ranking executive at Best Buy, a major American tech corporation. Kevin has served on the executive board of the Adult Congenital Heart Association, and he's been a very big donor to the ACHA. Kevin has been an absolute leader in this field, and Kevin has lived a very, very full and productive life. So, again, These are not just, diagnoses. These are actual
venga,
people.
venga, thank you.
If you don't mind muting yourself, if you're going to be on the phone, please, thanks. But the point here is that, even with all of these diagnoses, even with everything that's happened to this man, look at what he's been able to do with his life. And so really an amazing story. The Fontan operation. So let's talk about this a little bit. This is for patients like Kevin who were born with single ventricle physiology. But back when, Kevin was born, this was not an operation that had even been invented. And this is when it was first published in Thorax in 1971. For those of you that are fellows that think that the only way you're going to be remembered is if you participate in huge prospective randomized trials and you're first author of that, etc., I will tell you that Fontan here and Baudet published a series of just 3 cases. That's it, 3 cases where they did this surgery on patients and have been remembered thereafter. So some stuff that, doesn't require huge numbers if it's out of the box and really truly novel and truly game-changing. Unfortunately, Baudet kind of dropped off the radar. Nobody knows what happened to him. But Fontan became quite famous, and now it's known as the Fontan operation. Here are the various Fontan subtypes that have been developed. There are so many more subtypes of Fontans, but nowadays what we are seeing are basically the extracardiac and the lateral tunnel type Fontans. The old style right atrial to pulmonary artery Fontans, the direct cavo-pulmonary connection, has now replaced that for many reasons. One of the major reasons is just the right atrium, if you include it in the circuit, becomes severely dilated, and patients will have incessant atrial arrhythmias and really inefficient flow. So therefore, this has been completely abandoned, and the patients that still have this are either being transplanted or have been converted to these newer types of Fontan variations. What's the problem with the Fontan? Well, the Fontan essentially leaves you with very high central venous pressures and a low cardiac output state for your entire life. And that has consequences. What are the consequences? That first and foremost, your liver is exposed to a high central venous pressure. The Fontan is sort of like your best model of chronic severe right heart failure. Okay. And after 20, 30 years of this circulation, your liver is congested and eventually becomes fibrotic and eventually becomes cirrhotic. You have portal hypertension. You develop ascites. You develop splenomegaly, portosystemic shunts. Your kidneys are affected by this, and so on and so forth. So it's really becomes, much like the Eisenmenger syndrome, a multi-system disorder. And the ultimate therapeutic options for these are either transplantation, and this is actually a painting I did not too long ago of a patient of ours that many of you might have cared for, Damien Quarter. And I have the okay from all of these people to actually state their names. But, this is a guy who had dextrocardia and bilateral SVCs and all kind of hemorrhagic protein-losing enteropathy, etc. And, our surgical team, Dr. Van Arsdale, ended up doing an extremely creative transplantation, basically plugging the heart in upside down in order to make it work. And really the other area is mechanical support for this population. And unfortunately, we have not moved the needle on this, I think, enough over the years. And this is an area where, as a field, I think we need to move forward with figuring out more mechanical support options for this particular population. Their survival post-transplant, if we do a transplantation, has classically not been great. Fontan patients don't do as well as others. And if you look at this Kaplan-Meier curve here regarding post-transplant survival, and this is a dated paper from 2009, actually where they really suffer is early on. And what happens is they essentially do not make it, about 30% of them, through the first 6 months after a transplant. And the vast majority of deaths are occurring in the operating room or in the immediate post-operative period, driven oftentimes by heavy, heavy bleeding. They just hemorrhage everywhere. It's an absolute bloodbath. So these transplants tend to be transplants where 60 units of packed red cells, tons of units of platelets, FFP, you name it, Kcentra, everything is thrown at these patients to actually limit the bleeding that occurs. And so, we decided at UCLA years ago that we were going to tackle this problem and that we were going to find a way to actually get these patients as safely as possible through transplantation. And we made a kind of an institutional commitment to do this. We know that a heart and a liver transplantation appears to be better for these patients than heart transplantation alone. So the vast majority of Fontan transplants that we have done now in the past decade have actually been heart and liver transplants as opposed to just heart transplants alone. And this is data that we contributed to that was published in JACC, I believe it was last year, in the last 2 years. And then we also published this sort of how-to manual on how to do heart and liver transplantation in Fontan patients. And if you look right here at this diagram that we put into this manuscript, look at all the considerations here. So there are so many anatomic considerations that one needs to take into account. And then you have to have a real team mentality here in order to be able to do this. Look at how many teams need to be involved in this in order to get patients safely through this kind of transplantation. And so, thanks a bunch to our various colleagues from all of these different teams for working with us to make this happen. And thank you to, our own ACHD team here, and really a special thank you to Dr. Jeanette Lin on our team here at UCLA for helping us get organized and organize all these teams. She basically puts together a meeting, typically about once a month, where we spend 1, 2, sometimes even longer hours reviewing patients in great, great detail and coming up with an exact plan for how we're going to manage these patients. So what you have to do here is you have to identify teams, specialties that are actual stakeholders. You have to identify persons and leaders of each team. You have to have central coordination. And in our case, it's by the ACHD team quarterbacking this process, which makes sense because in the end, we know these patients very well and we understand this anatomy. We have to work very closely with our heart transplant and liver transplant teams as well on this. The cases are discussed very often, and we also review all the complications that we have and all the good outcomes that we have in great detail so that we know what we did right, we know what we didn't do right. And so therefore what we're doing is we're adjusting what we do, in really from case to case to make it better and better. It really is this sort of fine tuning that has to take place, on a regular basis. So let's talk about Skylar's story, and I'll just finish with this. So Skylar was born in 1993. He's 27 years old. He was born with hypoplastic right ventricle, basically the most severe form of congenital heart disease you can have. Pulmonary atresia, discontinuous pulmonary arteries. Here's Tyler intubated when he was a little tiny baby. At 3 days of age, he gets a Blalock-Taussig Thomas shunt. At 7 months of age, he gets a Glenn shunt. The takedown of the BTT, ligation of his azygous vein, his left SCC, 2.5 years of age, 8 years of age, 9 years of age. I'm not going to go through this in all the detail, but look at how many surgeries this guy has had, okay? And this is by the time he's 10 years of age, okay? And this is not even describing all the cats that he has had. By 25 years of age, he is failing at this point. Cirrhotic liver, heart failure, all kinds of arrhythmias. So he's referred to us from Spokane, Washington, for heart and liver transplant and gets listed at UCLA in 2021. Eventually, he goes to the OR in January of 2022. Here's Dr. Van Arsdale and the transplant team working on Skylar. Very challenging surgery, IVC, SVC anastomoses. Liver required significant mesenteric venous reconstruction, had to start dialysis in the OR to combat lactic acidosis, severe hemorrhagic shock, lung injury, diffuse bleeding, extensive hemostasis, 60 plus units of platelets, all kinds of pressors, etc. Transferred to the ICU, but heart's working pretty well. Liver function appears acceptable. And you know what? He gets discharged home I don't know, maybe a month later, a month and a half later, and he's done extremely well since that time. He has not had heart failure, no rejection, no infection. More than 2 years later now, he has started his own foundation for patients that require multi-organ transplantation. And he actually attended and spoke at our recent symposium on heart and lung transplantation. So this guy's become like the biggest UCLA fan. And look at him. He's a young man otherwise. He's doing really well. He's married. And it's just, a wonderful story. But it took so much to get him there. And that's the key here, is that ACHD isn't simple. It's hard, but it's worthwhile. So why don't I stop there for the sake of time, and I can take any questions.
Hi, Jamil. I'll start off. That was really fantastic. You may have been heading in this direction with that last slide, but was basically going to ask, is there data on the extension of median survival over the decades as these advances have been made? Because certainly it's apparent to those at UCLA, but I was just wondering if there was any national or international data that can kind of put an estimate on that.
Yeah, so great question, Greg. Thanks. I don't have it in this particular talk, but overall, yes, the demographics have changed completely. If you take something like single ventricle physiology, before the advent of the Fontan operation, your likelihood of surviving to adulthood was basically less than 20%. So it was the lucky few that would survive. After the Fontan operation, the majority of patients survived to adulthood. But what we've done is we've basically improved their survival, but now we've given them new diseases. So in the end, yeah, now they survive to adulthood, but they develop cirrhosis and all this end organ dysfunction by the time
Live long and
they are
prosper.
adults. What's that? I'm sorry?
I'm so bad at that. My fingers always feel strained whenever I do that. You're not Vulcan. Yeah, exactly. I guess I show.
Okay. Maybe whoever that is could just mute themselves.
Hey, Carol. Happy Friday.
Thank you. Or if you can mute them. Thank you.
Hey
Okay.
guys,
How are you?
that was a fun meeting.
So Carol, can somebody mute Carol perchance?
What was your general impression?
Thank you. Okay. Anyway, what I was going to say is that, yes, we have changed the demographics, we've changed the survival, but we've created new problems in doing so. And, the thing about survival of all ACHD is it's just such a grab bag of different diagnoses that you really, that doesn't make sense to look at it that way. So you have to look at specific lesions. Another area, for example, is transpositions. Patients with transposition of the great arteries used to not survive to adulthood. And then you had the mustard operation and the setting operation, which were atrial switch operations that allowed them to survive into adulthood, but with a systemic right ventricle that would then fail. And so we're transplanting a lot of those patients now. But then in the late 1970s and early 80s, in Brazil, Adib Jetin, a very famous congenital surgeon, did the first arterial switch operation instead of atrial switch operation. And so that changed the survival completely. And now an atrial switch operation, if done well, basically gives you the same survival as somebody who has a normal heart or very close to that. And so that's a great success story for transposition. And I can go on to, other areas, like this in specific diagnoses, but big picture, yes, we are improving things immensely. But our problem here, and this is where this slide matters, is the lack of access to care. And this is, again, dated from, 20 years ago, but this still applies. Less than 10% of ACHD patients are actually in subspecialty care at this point. We've done some things to improve this, and this is where the Adult Congenital Heart Association the accreditation program has actually gone a long way in creating a lot more centers, many more centers. You know, back when I started in this field, it was basically these were the places. Okay, it was us at UCLA, the Mayo Clinic, Toronto, or Boston, where you would go if you had ACHD and complex ACHD. Well, nowadays there's 58 accredited centers around the country where you can go. And I remember when we were beginning the accreditation program, there was a question of, well, what does it get us? We're on top of the hill, right? We're UCLA, we're the place where everybody comes. Why should we actually build other places up to deliver care? And I think all of us felt that that would be an irresponsible way to approach this field. And if anything, we've actually attempted to promote the development of health systems for these patients, not just in this country, but elsewhere as well. So thank you for your question, Greg. I hope I answered it.
Jamil, that was a great talk. Just had a question. Do you ever envision, since it looks like the critical time is the neonatal period, of maybe doing surgeries in utero and convert those VSDs and 20 years from now? Do you see that as a option?
Yes, actually, and that is already happening for certain things. I'll just use one example, which is critical aortic valve stenosis. So if you have very, very severe bicuspid or unicuspid aortic valve stenosis, then in utero, your left ventricle will not develop normal, and you'll have a hypoplastic left ventricle, and you'll be born with hypoplastic left heart disease, right, or left heart syndrome. And however, if you go in utero at around, say, the 20-22 week mark, and actually using a needle, a coronary wire, and a small coronary balloon, and you actually do a valvuloplasty on that fetal aortic valve, then that can completely change the natural history or unnatural history of that ventricle and that valve, and that patient may then be born with a left ventricle that's good enough to support a biventricular circulation. So yeah, we are in the early days of those breaking those barriers. I'm not doing that on the ACHD front, obviously, because I'm not a pediatric cardiologist, but I can tell you that that is an area that is being developed and that there's great interest in. So yeah, great question, Henry. Okay. Well, thank you guys. I appreciate everybody listening in, and thank you, Patrick, for asking me to speak. And if any of the fellows or anybody has any further questions, feel free to reach out to me, and I appreciate it. Have a great day, everyone.
Thank you.
Thanks so much.